Hello, everyone. Tonight, our topic is novel variants in KAT6B spectrum of disorder. It's the latest KAT6B publication by Dr. Arboleda and Megan. Am I saying your last name? Yabumoto, is it right? Dr. Arboleda, do you want to?
Sure. I can take it from here. I'm so glad that we had the opportunity to share with you some of the work we've been doing for the past couple of years. So Megan is actually one of the first undergraduate, she was the first person who joined my lab before I even had a space or an office. I still remember meeting with her in the hallway of where they said my office would be, like when I started back in 2017. And so Megan was an undergraduate at the time at UCLA and helped kind of work through the lab all up until 2020 when the pandemic hit, and she had been working in the wet lab on a variety of projects in the lab. And when the lab shut down, I think Megan went home, graduated from UCLA. I actually haven't seen her since COVID ended, but at the time there were a couple of cases of KAT6B that were identified at the UCLA clinics by Daniela Schweitzer and Debbie Krakow, who are also on this paper, and one of the genetic counselors. And they had approached me saying, well, this is similar, it's the same gene family as KAT6A. Are you at all interested? And I said, of course. So we talked about doing a small case report and with maybe one or two cases to just add to the literature, because we thought we had some new phenotypes here. And I think Megan had the foresight to say, well, why don't we just ask around and see if people have other cases they'd be interested in reporting, and we can make it into something bigger. And that's sort of where this project came from. I think Megan's suggestion and sort of having that, I think the work ethic to really pull this through in the midst of COVID, where it was challenging enough to do any sort of clinical care in medicine, let alone research. Megan was able to communicate with all of these different physicians and genetic counselors and pulled together a cohort of 20 individuals who had not been, I think only one had been reported in the literature previously, but we had more phenotypic data. And so that's really the story of where, how this started and where this came from. And sort of for us, it's always been something we've thought about in the back of our heads. KAT6A, KAT6B, how similar are they? They look very similar from a molecular standpoint as far as what the genes. This is me. This is Megan. Megan is finishing up her genetics counseling master's at Stanford, and so in a year you may see her as a genetic counselor wherever she ends up working. And then that's me. I'm an assistant professor here at UCLA in the Department of Pathology and Lab Medicine and in human genetics. And so I've been studying KAT6A and now KAT6B for a little bit of time, and we're really interested in trying to understand some of the more gene regulatory mechanisms underlying these disorders. Next slide. So a quick overview. Megan and I are going to tag team this presentation. So I'm going to talk a little bit about a brief introduction. We're going to discuss the main findings from our publication, and then suggest some potential next steps for some of the genetics research that we've done and that we're planning on doing. We'd like to keep this fairly informal. So if you have questions or want to just, if something we're saying is not clear, just please feel free to unmute yourself or raise your hand. I'm going to try and keep an eye on the hand raising feature, and we're happy to answer questions in the middle of the talk. So as many of you know, KAT6B is lysine acetyltransferase 6B. It's a gene that plays an important role in growth and development. And most individuals with a diagnosis of a KAT6B related disorder, typically these are what we call de novo and pathogenic variants. So de novo meaning that neither parent has this particular genetic mutation, but the child does. So it's new within the family. And they tend to be heterozygous variants, meaning you have two copies of every gene and the mutation affects just a single copy in the child. Next slide. The genetic cause for this KAT6B spectrum of disorders was first identified back in 2012, right when we started to do a lot of clinical exome sequencing across various clinically identified disorders. And so the first of these were genitopatellar syndrome, where they identified truncating KAT6 mutations in KAT6B for both genitopatellar syndrome and for SAB Barber-Biesecker-Young, I think in Young syndrome, Simpson syndrome, SBBYS. I can never remember all of the different names in there, but I think what this slide shows is that you have a cluster of mutations that tend to be where genitopatellar syndrome mutations are, and then you have a different cluster that appears to be where we see SBBYS syndrome mutations. And it looked to be fairly clear early on that there were sort of these two distinct categories, but as we started sequencing more patients and looking more at the clinical phenotype, it became fairly evident that there was a little bit more of a spectrum, and it was not as simple. So this is a more recent publication, so one of the more recent ones from 2020, just highlighting that heterogeneity across the KAT6B spectrum of disorders. And while you still see a very clear demarcation of GPS, genitopatellar syndrome, which is in blue, and SBBYS, which is in orange, there's very clearly individuals who don't fit into either syndrome or who have a mix or intermediate phenotypes, meaning they have some phenotypic features, but not enough of the core features to be called either GPS or SBBYS. Next slide. So there's a couple things that I think we as medical geneticists like to distinguish between these two phenotypes within the KAT6B spectrum of disorders. So for SBBYS, the major features include long thumbs and big toes, a mask-like face, problems with the tear ducts. But the things that they don't have, the patellas are normal. Is this absent or small patella? I thought sorry, did we mix this up, Megan?
It's still pretty mixed in terms of the reports, in terms of like how many individuals with SBBYS have absent or small patella, but it's definitely in lower numbers than in GPS.
Lower numbers than in GPS. And then congenital heart defects, differences in thyroid function, and global developmental and intellectual delay. For genitopatellar syndrome, so absent and small patella is still there, but there's differences in genitalia, joints that cannot be straightened, differences in the brain formation, kidney complications, and then the things that are still in common are this global and developmental intellectual disability, congenital heart defects, and problems in thyroid function. So these are sort of the major features around both disorders, and you can see that there's an overlap across the two syndromes. So even the naming of the syndromes is less clear than it has been. In the past, I used to think of the patella as one of the more distinguishing features. So as more individuals with KAT6B related disorders are included in research studies, we observe this greater variability and overlap across both phenotypes. And so now I think there's been another section of an intermediate phenotype and also a not otherwise specified phenotype.
Okay, thanks, Val, for that brief introduction. I'll just go ahead and dive a little bit more into our specific publication. So our case report includes 20 individuals with the diagnosis of a KAT6B related disorder. And to break that down even further, 7 with a diagnosis of genitopatellar syndrome, 8 with SBBYS, and 3 with an intermediate phenotype, as well as 2 with diagnoses not otherwise specified, so lacking the major features of either GPS or SBBYS. And these individuals came from 12 different centers across the country. And among these 20 individuals, we were able to identify and report on 10 variants in the KAT6B gene that were not previously included in the literature. And it's important to add all of this information about variants that are newly reported, as well as the 7 variants that were found in our cohort that have been reported to the literature to give families more information and insight as to what to expect. And for our study, we collected information about specific clinical features and patient experiences with genetic counselors directly from the collaborating providers. And then here's a diagram we put together to show that the majority of individuals included in our report were on the East Coast and West Coast of the United States, mainly where there are large academic medical centers with genetic specialists. And within our study, we focused on 3 main areas of interest. The first being more detailed information about the clinical features of individuals in our cohort during infancy, childhood, and early adulthood. The second being an exploration of experiences with genetic counselors. And finally, the third being cell-based studies, which Dr. Arboleda will go into a little more detail towards the end of the presentation. And so within our cohort, about 56% of individuals received a genetic diagnosis of a KAT6B related disorder before the age of 2 years old, meaning they had genetic testing through either multi-gene panel or exome sequencing that confirmed this diagnosis. And we wanted to highlight that 25% of individuals were male and 75% were female. And age of individuals at the time of data collection ranged from as young as 6 months old to as old as 28 years old. And in total, we included 3 individuals who were 20 years or older, which is important to better understand clinical features over time, although these 3 individuals were all very different from one another. And then here I wanted to highlight some pictures of our cohort we were fortunate enough to have with written consent from their parents. I especially wanted to point out panel B down below, which allows us to better understand how facial features might evolve over time. And you may be able to observe from the slide that some features related to the eyes and the rounded tip of the nose remain prominent over time. And here I wanted to highlight some of the major skeletal features that many individuals with KAT6B related disorders have. And this includes the long thumbs and long big toes, absent or small patellas, and contractures, or the difficulty in extending joints all the way. Okay. And then within our publication, we were able to highlight some features that were observed in a large majority of the individuals in our study. And so these include developmental delay and intellectual disability, which is seen in each individual in our cohort, although we did see a broad spectrum from mild delay to severe disability. There were also feeding difficulties that were reported in all but 1 individual, and many individuals ended up needing feeding tubes and had reflux or constipation. 75% of our cohort reported findings related to visual impairment, including differences in the nerve in the eye and differences in tear duct formation, as well as 75% having differences in the structure of the heart since birth. And we also wanted to point out that 55% of individuals experienced respiratory distress, and 5 of these 11 individuals had obstructive sleep apnea that may require things like CPAP machines to help them sleep. Okay. And then we also wanted to point out some features that were reported more frequently in our cohort compared to the rest of the literature on individuals with KAT6B related disorders. And this includes joint hypermobility. So 60% of our cohort reported some form of joint hypermobility in the hips, knees, fingers, things like that. But previous reports had identified joint hypermobility in 7 individuals across all reports. There was also a higher incidence of recurrent infections, including urinary tract infections and recurrent ear infections in individuals in our cohort. We also observed higher rates of fractures of the femur, tibia, and fibula, so the major bones in the legs, and higher rates when compared to the individuals in the rest of the literature. And of note, some individuals within our cohort had more than 1 fracture. We also identified sensitivity to light or noise in 2 individuals, and this may be a feature that could go unreported or underreported in young children as well. And finally, I wanted to highlight that 5 individuals in our cohort had a history of seizures, and up until this point, seizures had only been reported in 6 individuals total across previous reports. So a decent amount of new findings that are all pretty much detailed in our publication for your reference as well, because I know that was a lot of information. And given all this information, we wanted to emphasize the point that providers need to take a multi-system approach to the routine physical exam. We also wanted to acknowledge that some features may have been underreported by providers due to the lack of recent examinations during the COVID-19 pandemic. In here, I just wanted to call out this table of recommended surveillance that you and your providers can find on the Gene Reviews page for the KAT6B related disorders. And then finally, the last part I wanted to touch on was our findings about experiences with genetic counselors. And so this had been based on a survey we had actually sent to genetic counselors and providers to report on their interactions with families immediately after diagnosis. And so here I wanted to highlight that 85% of families met with a genetic counselor at least one time, and individuals received a genetic diagnosis as early as 6 weeks old and as late as 22 years old. And the two main findings I wanted to highlight is that when a genetic counselor was able to provide a family with the diagnosis, the most immediate questions were around prognosis or what to expect in the future, especially for concern for other medical complications, especially because many patients were very young. And some of the challenges that genetic counselors face when relaying the new diagnosis is trying to address many questions surrounding how complex the phenotype and KAT6B spectrum of disorders can be. It can be difficult to make this diagnosis because there's limited information and resources about the complexity of KAT6B related disorders, sometimes forcing us to sit a lot with uncertainty. Okay, and then the main points we wanted to call out for genetics providers and genetic counselors was the idea that needs evolve over time. And our role as genetic counselors is to continue to evaluate where families need support to improve the way we guide families through difficult conversations. And this holds true for every patient and their families affected by rare genetic disease. And we do acknowledge that our survey only captured a select amount of experiences and perspectives of families, and we imagine additional work can be done to characterize the needs of families. Okay, now I'll toss it back to Val for discussion on some of the cell-based studies included in our study.
So one of the last pieces that we put into this particular paper was we developed a cell model by introducing KAT6B variants. So essentially we mutated the copies of KAT6B in a human cell line. And we really asked the question, like, how do these variants affect gene expression and the way the nucleus is organized? And so we observed some differences in the way genes are expressed, and we think that this may at least provide a snippet of insight into the common clinical phenotypes that we see with KAT6B related disorders. Particularly, we think that some of the findings we have sort of are consistent with what is seen in patients with the incidence of fractures and skeletal anomalies, the intellectual disability and kidney differences. And I should be very clear that the cell-based studies sort of point in a direction and sort of let us know which genes may be driving that effect, but it's still fairly early on. And so I'll talk about what we find and some of the things that are good about the model we use and some of the things that I think could be done much better. So this is just an overview of what the cell-based model is. Essentially, you can use CRISPR-Cas9. So this is the new gene editing technology. You can introduce this complex along with the protein into the cell line and cause a mutation in the cell line. It's a simple process, but to do it well without affecting other genes aside from KAT6, the gene that you're trying to target and the specific mutation you're trying to make, can be kind of challenging. But once you have the cell line made, you can do a lot of things. You can query what the RNA looks like globally across in the entire cell. You can look at protein levels, you can look at metabolites. You can assay things like how well the cell proliferates, how well it grows, and how many cells die with the mutation. And then you can assay things like drug response. So it's a really powerful tool. You can do a lot of things that sort of depending on how creative and how much genome engineering you want to do. You can do a lot of things in the cell line. So what we did is we introduced these mutations and then we looked at the RNA transcriptome. So the RNA is the building blocks of your protein. It's the in-between step from your DNA to protein. And so this tells you what kind of proteins you can actually make in your cell and what those proteins look like. So we took this cell line, which is HEC293, it stands for human embryonic kidney cells. And we have wild type, so we have what our control lines here on the left, control 1 and control 2, run and replicate. And then we also have mutation lines. So we made two different lines and we ran them in duplicate. So we essentially wanted to make sure that anything we saw was not just by chance alone. And so you can see that there are really significant differences between the two groups. We see a number of genes that are here in blue are upregulated and a number of genes that are downregulated in the cells that have KAT6B mutations. And what we can start to do here is we can identify markers of disease. So we can identify RNAs that are differentially expressed, so things that go up or down in the presence of due to the KAT6B mutation. And then we can start to look for pathways that you can say, well, if I think about it, if you have a therapy or a target in mind, you can ask that question, if I treat with this target, does it change the level of these biomarkers, which is here, in this case, your RNA. Next slide. So when we take just all of those RNAs that are different between KAT6B mutation cells and the controls, and we say, when you look at these RNAs or these genes that are changing, where do we typically see them, in what processes in development? We can feed them into these, what we call gene ontologies, and we can ask this question, what processes are these genes often seen in? And so we have several hundred genes, and we ask whether or not you're more likely to see them in certain processes. And these genes tend to fall into these categories. And so like I mentioned, we saw a lot of things initially that we weren't, we did this study actually before we looked at all the patient data, and we saw a lot of interesting differences that were related to ossification. So this is how well your bones mineralize, or osteoblast differentiation, how your bones actually grow and repair themselves. And so we kind of looked at this and we weren't really sure what to make of it. And then as we were doing the KAT6B clinical phenotype, we said, well, actually, this makes more sense than we thought it did. We were mostly looking for, to be honest, we were mostly looking for a lot of brain development types of processes and cells. The challenge here is that we're working in these human kidney embryonic cells. So they're not exactly the cell type you would want to study for anything neuro-related, because they're not neurons, they're kidney cells. And genetically, not only did we introduce a KAT6B mutation, but these cells are triploid. And so triploid meaning they have 3 copies of every allele, versus as all humans have 2 copies of every allele. So these cells are good. The reason people use these cells is because they're very easy to grow and they're easy to introduce the any mutation into. So they end up being sort of an easy cell line to work with, but the downside being that they're not necessarily representative of exactly what happens in any given process in the cell. So if we're interested in brain development, you can only go so far in a human embryonic kidney cell. Next slide. So I think some of the next steps that we're actively thinking about is to sort of all of these genes, many of the genes that and the mutations should be studied in cell and animal models that capture disease complexity. My research lab is really interested in these induced pluripotent stem cells. And so what this means is we have cells that we obtain from either blood or skin biopsies, and we turn these cells into iPS cells. So these cells are like stem cells, and they can differentiate into a lot of different cell lines in a lot of different tissues or representative of tissues across the body. So we can model things like early brain development, we can model heart development. Right now, it's hard to do everything at the same time. So this is just a model of how you would model early brain development. So we're making what we call brain organoids. So it's a recapitulation of early brain development from the neuroprogenitor cells all the way through the neurons. And you can see here, these are just the different factors that we use to grow them up. We have a number of cell lines, mostly around KAT6A and a couple other disorders. We actually don't have any KAT6B cell lines in our laboratory, so we haven't gone this far for any KAT6B, but we'd be very interested if people are interested in donating blood or fibroblast samples. Next slide. So, I mean, that's sort of where our study has ended. We thought it would be really valuable to add more individuals to literature to better understand that spectrum of heterogeneity. We know it exists in KAT6A. It also exists in KAT6B, and I think it's not as clear cut as people thought it might be early on, that you could really distinguish it as two separate disorders. And I think the unique thing that our study adds is we have more reports from some patients who are older, who have a long clinical history with their providers. So we can capture more of that history that's important, especially for some of the younger patients and families. And I think Megan, as a genetic counselor, a lot of her interest is around how she as a counselor can better support families going through the diagnostic odyssey, because I think especially with rare disease patients, it's challenging in that we don't have a lot of information. The individual sits in these silos that are, and it's hard to get all that information to the family and to even give a good prognosis of what you might need, because we're still learning as a community what needs the patients have as they grow older. And a lot of early genetics has been around the diagnosis, but we're really trying to make an effort to expand beyond the diagnosis and make sure that along the course of a patient's life, we can really model how the needs change over time. Next. So we just wanted to thank the KAT6A Foundation for giving us the opportunity to share our work. A huge thank you to all the patients and families for their participation, and to our colleagues who took the time out of their busy days to recontact their patients and the families and kind of collect the information back in, July of 2020, when we were really putting this together. And then next slide. And then I just wanted to acknowledge a couple people in the laboratory. So Meghna Singh and Maria Palafox, Angela Way, and of course, Megan. All of them really played a key role in getting this project off the ground. And the wet lab work was, I forgot to mention, and Kate Elliott, who's also a genetic counseling student, who made the models, who did the different assays and did the analysis for us moving forward. So we are happy to answer any and all questions. I've tried to answer some in the chat, but please feel free to ask us any questions you might have on anything in here in these slides, and or not.